Hello everyone and welcome to today's webinar. Scottish Drugs Forum are hosting the webinar along with the Drug Death Taskforce, the Medication Assisted Treatment Programme team and its Benzodiazepine Working Group. I'm Dave Little, CEO of SDF, and I'll be chairing today's webinar. As most of you attending today fully appreciate, Scotland is facing significant challenges due to problematic use of benzodiazepines, most often in combination with other drugs. Recent changes in the type and range of street benzodiazepines has led to increased supply and reduced prices, which are a key driver in increased overdose deaths in Scotland. In 2019, benzodiazepines in combination with other substances, most often opioids, were implicated in 64% of the 1,264 drug-related deaths in Scotland. In the context of increased benzodiazepine-related mortality and the lack of robust clinical guidance, there is a need to develop a Scottish response to address the harms associated with benzodiazepine use. Scottish Government's medication-assisted treatment standards, published earlier this month, aim to drive access, choice, and evidence-based support in drug treatment and care. There is a pressing need to adopt this approach in relation to benzodiazepines. This webinar will introduce actions from the Benzodiazepine Working Group to develop national treatment guidance and reach consensus on person-centered approaches to the management of benzodiazepine use and related harms. Today's webinar will provide an update on work to date and invite your involvement. The next phase of the work will contribute to the implementation of the standards. Today's webinar will feature contributions from Andrew Macaulay, Senior Research Fellow, Glasgow Caledonian University, Joe Schofield, Research Fellow, University of Stirling, Claire Campbell, Consultant Clinical Psychologist, Aberdeenshire Integrated Drug and Alcohol Service, Isabel Trainer, Consultant Clinical Psychologist, Head of NHS Fife Addiction Psychological Therapy Service, and finally Trina Ritchie, Lead Clinician and Senior Medical Officer at Glasgow Alcohol and Drug Recovery Services. The webinar will conclude with Claire Campbell describing the next steps of the working group, including the consultation on the National Treatment Guidance. So let's get started with our first presentation. Our first presentation is from Andrew Macaulay. Andrew is on leave today, so this is a pre-recorded presentation. Thank you.
Good afternoon, my name is Dr. Andrew Macaulay. I'm a reader in public health at Glasgow Caledonian University, and I'm going to be talking about the rise of benzodiazepines in Scottish drug-related deaths. Benzodiazepines are amongst the most widely prescribed psychotropic drugs in the world. Over the last 30 years, Scotland has had a strong relationship with the misuse of benzodiazepines, from temazepam, diazepam and triazolam in the mid-1980s to atizolam, phenazepam and other new or novel psychoactive substances, or NPS, in the 2010s, often referred to as street benzodiazepines. And what we can see within this graph is that benzodiazepines in Scotland are now operating within an environment where prescribing in primary care has steadily reduced over the last 20 years. In part, these reductions are due to concerns about benzodiazepine dependence and inappropriate prescribing, have been achieved by general practitioners and prescribing support teams working to review and reduce benzodiazepine and hypnotic prescribing where appropriate. Increasingly, the illicit market supply of benzodiazepines has replaced and superseded the availability of benzodiazepines on prescription. These posters taken from a GP surgery in Scotland give an indication of the special attention benzodiazepine prescribing has received and continues to receive in recent years. In contrast to the decrease in benzo prescribing over the past 10 years, benzo-related mortality has been increasing, especially in recent years. Benzos have always been heavily present in toxicology, but not always deemed to be contributing to the cause of death. This trend has changed in recent years. In 2019, benzodiazepines were implicated in or potentially contributed to 888 deaths, or 70% of the total. Street benzodiazepines such as atizolam accounted for the majority of these deaths, 814 or 64% of the total drug-related deaths for that year. And prescribable benzodiazepines such as Diazepam accounted for a much smaller minority of cases, 195 or 15% of the total. The increasing role of street benzodiazepines in drug-related deaths over the past decade has really accelerated in the past 5 years. In 2015, only around a quarter of drug-related deaths involved a benzodiazepine, compared to 70% in 2019. The majority of the recent rise in the figure for street benzodiazepines is due to Diazepam, which has seen a remarkable rise in the past 5 years. Information from the National Record of Scotland database shows that Diazepam was implicated in or potentially contributed to the cause of 752 deaths in 2019, representing almost 85% of the overall benzodiazepine-related figure of 888 for that year. Put another way, almost 2 in every 3 drug-related deaths in Scotland in 2019 involved Diazepam. The almost vertical trend observed in Diazepam-related deaths in Scotland in recent years mirrors the impact of synthetic opioids in the overdose crisis in the USA. In this case, it is mainly fentanyl that has driven the third wave of opioid overdose deaths following a tightening of opioid prescribing in the early 2000s. Diazepam has had a similar effect following the tightening of benzodiazepine prescribing in Scotland from around 2010 onwards. Changing trends in benzodiazepines matter because these drugs are rarely taken in isolation. They are typically consumed alongside opioids and alcohol, and also increasingly gabapentinoids and cocaine, increasing the risk of overdose for the users. These new benzos can often be much stronger than diazepam. Drugs such as flualprazolam are much stronger and also behave differently. Drugs like Diazepam have shorter half-lives, making users much more likely to redose. The combination of stronger drugs and redosing places users at increased risk of harms. These risks are compounded by how these drugs are often marketed. There is evidence of them being branded and sold as Diazepam, but containing street benzos or even other drug compounds, meaning users are taking them unknowingly and engaging in a game of consumption roulette. This recent review of Diazepam concluded that it had a shorter half-life than other benzos, especially Diazepam. This means that the effects wear off quicker and users are much more likely to redose. Also, although Diazepam is not known to be more lethal than Diazepam in laboratory studies, it is considered 5 to 10 times more potent when used to treat anxiety. However, a key gap in the research of Diazepam is in its relation to its non-prescribed use through megadosing, which is typical of the consumption behaviour we see in Scotland, where users talk about consuming in handfuls, way above the recommended dosage for individual use. This seizure evidence from Police Scotland highlights how the street benzo market operates with no care for the end user. In these tablets branded to look like Diazepam, the user is presented with a tablet containing a mixture of street benzodiazepines and a synthetic opioid. In this slide, we highlight how the market and the supplies available within it have evolved over time to mirror a range of prescribed medicines. And this continues to be the case month on month, year on year, as the market adapts to the environment it is operating in. Also, the market has developed from one where pills were largely imported from overseas to one where they are now increasingly produced domestically. As a result, street benzodiazepines in Scotland have never been more available or affordable. This slide captures one of the domestic labs the police intercepted a couple of years ago. The pills are visible in the pink basket on the left of the pill press, and these benzodiazepine operations are capable of generating thousands of pills each day, returning huge profits for those involved. So in summary, there is high demand for benzodiazepines amongst people who use drugs in Scotland, certainly alongside other drugs. There's a shift from diversion of prescribed benzos to street-based illicit benzos, and this shift has really increased the risk environment for users, especially over the past 5 years. Street benzodiazepines are now increasingly produced domestically, therefore less affected by international markets, and we saw that during the COVID lockdown periods where the availability of benzodiazepines was not interrupted at all. And policy and practice responses require flexibility and innovation if we are going to address this key issue affecting our drug-related death rates at the moment. Thank you.
Thanks to Andrew for that contribution. We'll now move on to our second speaker, which is Joe Schofield, Research Fellow at University of Stirling. Joe.
Thanks, Dave. Hi, everyone. Thanks for the opportunity to speak today. So yeah, I'm here giving a brief overview of some of the evidence, such as it is, to help inform management of benzodependence in Scotland. I'm going to briefly outline 3 areas. First is some info that probably will be familiar to people, the level of benzo use among people who use drugs. Second, look at some evidence from around the world around prescribing and psychological support to help people with those issues. And I'll just finish by briefly outlining a couple of pieces of Scottish research that are currently underway that should support development of guidance and practice here. So a key systematic review from 2019 looked at 351 international studies around benzo use. You won't be surprised to hear that studies found that more than 40% of people who use illicit drugs also use street benzos. Motives for this included self-medication, improving emotional states, and some polydrug use related issues, such as enhancing the effects of alcohol and opioids, managing opioid withdrawals, and also managing the come down from stimulants. Problematic benzo use was associated with more severe addiction. Polydrug use, as I've indicated, and especially among people with anxiety and mood disorders. Benzo use has been found to be higher among people who are in medication-assisted treatment. So that's addiction treatment that might be based on methadone or buprenorphine with other supports. And there's conflicting evidence in the literature on the role of factors such as age, gender, housing, and education. I just wanted to highlight some links with recent Scottish work following on from this. Some interviews that were conducted here with people who use street benzos, again, found motivations included self-medication of anxiety, sleep problems, and trauma. And also people highlighted the ready availability and low price of benzos contributing to the use. NHS Lothian Lab provided us with some of their data. They'd been doing oral fluid testing on samples from people who are in drug treatment services. And each quarter during 2018-19, an average of 43% of people were found to be benzo positive. So again, highlighting the link between benzo use and people who are on addiction treatment. This was supported by a recent survey we did of Scottish addiction prescribers. We asked them to tell us what proportion of their opiate-using patients have a problem with benzos. And this chart shows on the left in blue, it was estimated that the median proportion of people with a benzo problem was about 20% when they first presented to services. This increased to around 30% among people currently in care. So again, suggesting we may be seeing an increase in benzo use while people are on treatment, which is a concern. So then we've looked at some international evidence around what can we do to help people with the benzo problem. And first of all, thinking about prescribing drugs, including other benzos. Bandrup's study was a quite a large-scale international review of pharmacological interventions to help people reduce and stop benzo use. It looked at 38 randomized controlled trials with a collective 2,500 patients. These studies, they looked at examining the effects of a range of medicines. Now, these included antidepressants, pregabalin, beta blockers, and even homeopathic products, so quite a diverse mix. The team found that generally this was really poor quality research, very small trials, the methods were questionable, and the reporting wasn't great. The authors noted there was a high risk of bias. For example, many studies were funded by manufacturers of the drugs that were under investigation, and worryingly, the tolerability and safety of these medicines was poorly reported. Another issue is, and we find this consistently through the literature, a lot of studies around benzo use have been conducted among what I've put here, the general population. Many studies exclude people who have got what's known as substance use disorder. So the group that we're most interested in are often ineligible for many of these studies. And at the end of all this work, the authors said it's not possible to draw firm conclusions regarding pharmacological interventions to facilitate benzo discontinuation in chronic users. The theme of a lack of good quality evidence that's relevant to the people we're most concerned about is going to be a common one in these slides. So now moving on to think about beyond prescribing, clearly there's a need for psychosocial support for people who've got an issue with benzos. There was a large Cochrane review conducted relatively recently by Darker and colleagues, looked at 25 studies with over 1,600 people. These studies covered a very wide range of interventions, from relatively minor interventions such as sending a letter to a patient advising them to think about the benzo use, through relaxation, interviews, various forms of online counselling, through to more robust programs of support such as CBT and motivational interviewing. Overall, they found that a combination of CBT, which is where you support people to understand some of their feelings and triggers and behaviors, that combined with tapering, that's reducing the dose gradually over time, was found to be much more successful than either no intervention or just reducing doses. Brief interventions such as letters and interviews, again, were found to be better than nothing. But again, I wonder how relevant the evidence from a study that sent a letter to a GP patient who might have been on a small level of benzos for many years. I wonder how comparable that is to some of the people with multiple complex needs who we're thinking about today. And again, unfortunately, a large-scale international study, yet again, saying there's insufficient evidence for a range of interventions. The studies that have been done are generally very poor quality, very few patients, which makes it difficult for us to learn from them and apply them to Scottish practice. And again, regrettably, so few studies have been done with people who use other drugs that the results are generally not very translatable to addiction settings. So having painted quite a bleak picture in terms of some of the international evidence, we've realised there's a need to do work within Scotland to help inform policy and practice to improve services and outcomes for people. I'll just outline two studies here currently underway. One is a data linkage study that's going to look at 10 years of data from Public Health Scotland, and that's going to look at prescribing activity and patient outcomes. So we're interested specifically in people who are on opiate replacement therapy, methadone, buprenorphine. We're going to look at how many of them have been prescribed benzos while on treatment. And for all patients, we're going to look at outcomes, including drug-related death, all-cause mortality, hospitalizations, and retention in addiction care, to try and get some understanding of whether prescribing benzos to people in addiction treatment can be shown to be beneficial or harmful. Results from that are due at the end of this year, and that's been funded by the Drug Death Taskforce. Another project that's recently started that's very relevant to today, the Katrina Matheson's leading a study that's going to design and test an intervention in Scotland for people with the benzo problem. This intervention will probably include elements of prescribing, prescribe benzos as a safer alternative to street benzos, with psychosocial supports and interventions. This will be co-designed with people who use benzos and with healthcare professionals. Once that's designed, we're going to test how feasible and acceptable it is to folk in Grampian, Lanarkshire and Lothian. Results are due next year, and again, that's been supported by the Scottish Government. The goal is that both these projects will report relatively quickly and provide evidence to inform the guideline development you'll hear more about shortly, and developments in practice across Scotland. So finally, just to summarise, we've looked at some of the current clinical and research evidence and guidance. Very few studies relevant to our populations, generally poor quality, and generally done among generic adult populations, maybe prescribed at a GP practice, not in addiction treatment. Many of the studies they've looked at have looked at very minor level interventions, such as sending letters or a one-off reminder to people they might want to think about reducing, which I don't think is going to be that helpful to many of you service providers watching. So therefore, we've got limited evidence related to reducing and stopping problem benzo use for people who use drugs or are in medication-assisted treatment. Supporting people to reduce doses, including considering prescribed benzos where appropriate, and relevant psychological and social supports seem promising. International evidence base is generally lacking, but we recognise there's an urgent need to act in Scotland to reduce harms from street benzos. And I've mentioned a couple of pieces of Scottish work underway. First, some very focused research, and secondly, the clinical guideline development that clinical colleagues will talk to you about in the rest of this presentation. Finally, there are some references which I'd encourage people to look at if interested, and thank you for listening.
That's great. Thanks, Joe, for that good overview of where we are currently. I'd now like to ask Claire Campbell, who's chair of the Benzodiazepine Working Group, to present. Thanks, Claire.
Good afternoon. I'm here today in my capacity and role as chair of the Benzodiazepine Working Group. This is a drug death Taskforce initiative and sits under the Medication Assisted Treatment Programme. I also have a clinical remit, both within NHS Grampian and NHS Tayside, within drug and alcohol services. And I'm here today to talk about the steps that have been taken to get us to producing the interim guidance we're presenting today and to this webinar. The purpose and remit of our working group is to review the evidence within the Scottish context, some of which Joe has already referenced, and to map and share the current good practice that is going on in Scotland today and to learn from that. We're developing interim guidance around both pharmacological and psychological aspects of care. And our working group has a specific focus on those who are using both benzodiazepines and opioids who are arguably at most risk of harm. We wish to meaningfully engage with all stakeholders, particularly those directly affected by benzodiazepine use, to ensure that they're meaningfully informed, included, and can contribute to the work. Overall, we wish to establish a national consensus to have a clear response to problematic benzodiazepine use within Scotland. The working group had their initial meeting on the 9th of December 2020, and as illustrated on the slide, there have been a number of actions that have brought us to this webinar today. In December and January, there was a mapping exercise looking at current guidance around prescribing and psychological aspects of care across Scotland, and early consultation with family members and those with lived and living experience, which I will talk to in a moment. In March of this year, we made an early recommendation to the Drug Death Taskforce with a specific request to look at resourcing safety and stabilisation beds, residential beds, to provide immediate physical safety from those at most risk of harm from benzodiazepine use. We are currently in the process of mapping out current models of care and capacity across Scotland, looking at the characteristics of each service, and this work is continuing. The last few months have been spent developing the guidance that we present this afternoon, and this has involved early consultation with prescribers in Greater Glasgow and Clyde and with some of the early consultation group. This initial feedback has also informed the guidance that we present this afternoon. I'd like to take this opportunity to thank all of those people that have been involved in the early consultation process, those facilitating discussions, and particularly those family members and people with lived and living experience, because your views are important. Due to time constraints today, I'm not going to be able to talk to all of the points that have been made, but you're aware that this consultation process is ongoing, and I've attempted to pull out the themes as they emerged. Many people had positive experiences of services, but also many spoke about a rejecting response, about feeling that attempts to discuss benzodiazepine use, and importantly their concerns, were often shut down. People didn't want to have that conversation. And what was of concern was an increasing sense of hopelessness, where people felt that they weren't cared for. Many people talked about the importance of connection and of a feeling that being connected to others was important. And in the absence of having those connections with others, people became more strongly connected to the relationship with their benzodiazepine use. I've put the point unrealistic medicine on this slide because we all know that the principles of realistic medicine include collaborative, shared decision-making with a personalised and individualised approach to care, where a person is able to ask questions about treatment options and the pros and cons of same, and also be able to challenge those decisions. Many people that we spoke to said that this has not been their experience in attempts to get support with regards to benzodiazepine use. And the word realistic is important. For many people who were offered support, this often involved a short-term detox. And for many people, they felt that this wasn't realistic, when in terms of where they were at in their life, they were not in a position where they felt able or ready to make a change to stop their use. There was also a real fear about the fact people using benzodiazepines right now in Scotland know that every time they do that, they are taking a risk because they don't know what's in the tablets that they're taking, and that leaves people feeling really frightened. Stigma, unsurprisingly, is a known barrier to accessing support, and again, this was discussed at length. Interestingly, though, this wasn't just about struggling to access support for substance use, it was also about accessing the appropriate support from the appropriate service providers at the right time for both mental and physical health difficulties. Many people, therefore, have found themselves caught in a vicious cycle where being unable to access and have appropriate choice and support has meant that they're having to further rely on benzodiazepines to cope. Psychosocial and psychological support was also recognised as being very important, but there was a recognition that in order to engage and to benefit from these interventions, there needed to be a sense of safety and stability, with prescribing as an important component. It was also discussed about the need to support involved family members, because very often when a person is unable to access the right supports for substance use and co-occurring mental and physical health difficulties, it's often family members that are left having to cope, which has an impact on their own health and well-being. There was a recognition that services are doing their best and are often under-resourced, and there was a real sense of being able to support the workforce and consideration of appropriate training. Feedback that we have had on the interim guidance has been fairly positive. It's been considered a step in the right direction and a good idea. What has come across incredibly strongly, though, is that relationships and trauma-informed responses are important, and in fact should come first. It should come before anything else. Those who spoke of having really positive experiences talked about often, it's the relationship that you have with the person offering care, moreover than the intervention itself. Prescribing assessments should be an offer, not an ask. There's great inconsistency at the moment in Scotland with the responses that people experience. And again, it's around having that individualised care. There's not a one-size-fits-all approach, which you will see is reflected in the interim guidance. It was also recognised that based on that assessment and based on the formulation, that understanding of the person, that prescribing might not be suitable for all. But what's important is that people are able to have a conversation about that there is a thorough assessment of risks of prescribing, but also the risks of not prescribing, and that being a shared decision. MAT, medically assisted treatment standards, are not just for opioids. MAT is for all, and all substances include benzodiazepines. Review and additional support was important, including psychological support. But there was a sense that some people needed to be supported to access support due to fear, anxiety, and also perhaps of just having chaotic lives and the impact of substances on cognition, which means sometimes just organising your time and day to get to appointments might be quite challenging. It was accepted that monitoring has its own challenges. If somebody's prescribed a benzodiazepine, it's not always possible to know if somebody is maybe using on top of that prescription, and that was acknowledged. Again, there was a real cry for respite and immediate places of safety for those at most risk of harm. In essence, this webinar today is a call to action. As Joe has clearly articulated in his earlier presentation, the evidence base for both psychological and prescribing interventions in a Scottish context is woefully lacking. Whilst it is great to hear that there is ongoing development of the evidence, everybody here attending today knows we don't have the luxury of time to wait for the evidence to tell us what in many ways we already know, that the current status quo is unacceptable. The Benzodiazepine Working Group are unanimous in their position that there needs to be a different approach and a different response to what is a public health crisis, with the person at the front and centre of their care, and where establishing and maintaining that therapeutic relationship is key. Today we present our interim guidance around principles of care, benzos. I'm going to talk to this briefly, and then my colleagues Isabel and Trina Ritchie will talk more to the offers of benzodiazepine harm reduction in particular. Firstly, be prepared to have the conversation. Be prepared to have conversations and be willing to have conversations with people about their benzodiazepine use. It's an offer, not an ask. Listen to the person, seek to understand. People are using benzodiazepines for a reason. We therefore need to understand what those reasons are and to hear those reasons in order to develop an appropriate benzodiazepine care and treatment plan. The ethos of same-day treatment within benzodiazepines will be the start of this conversation, to listen, to assess and understand. We understand that it's complicated, but we need to have these discussions. Needs-based assessment. A person should not be defined by their benzodiazepine use. They are more than that, and they have lives. Our assessment therefore needs to be holistic, person-centred, and consider not just their use of benzodiazepines, not just biological factors, but also consider what else is going on for this person in their life right now, looking at psychological factors, motivation to make changes, motivations to keep using, what else is happening within their social context. This is important because this thorough assessment are like pieces of a jigsaw, which fitted together provides a unique understanding of why this person and why now, and importantly, what treatment and supports will they need in order to be safe and to achieve stabilisation. The zone of tolerance really is around the principles of realistic medicine and collaborative risk-taking. I am not going to talk to the risks of prescribing of benzodiazepines because it's well documented, and I would argue is one of the main reasons why the conversations and assessments for benzodiazepine prescribing do not always happen. Instead, what we're saying is that there needs to be an assessment of whether prescribing interventions and any interventions are appropriate. These decisions need to be shared, it needs to be collaborative, and today we're saying that for some people, a decision not to prescribe may perpetuate harms. Offering benzodiazepine harm reduction at that first point of contact, whether that's offering harm reduction advice or appropriate psychosocial and psychological support. Particularly to respond to the harms of benzodiazepine use, we would consider psychologically informed care, establishing and maintaining that therapeutic relationship, assessment, including risk assessment, skillful goal setting and harm reduction would all fall within that psychologically informed care. Psychosocial interventions to support substance use, benzodiazepine dependency and co-occurring mental health problems will be directly informed by the assessment and formulation of that person's difficulties. To illustrate, I could use an example of somebody who presents with benzodiazepine use who's describing sleep problems. We may consider offering sleep hygiene advice. However, without understanding the reasons that underpin the difficulties with sleep, we are at risk of that intervention not being as perhaps effective as it could be. For example, if a person's sleep difficulties are related to their experience of chronic pain issues, then it would be appropriate to offer support to access treatment for that, and assessment and treatment for those pain issues alongside sleep hygiene. Again, if somebody's sleep issues are related to their experiences of trauma, sleep hygiene advice and isolation of psychoeducation around trauma would be less effective. So again, the thorough assessment and the psychological formulation is key to highlighting appropriate interventions. Benzodiazepine harm reduction interventions should also include an assessment for prescribing. It should also include an assessment to support those who may wish to self-detox. Prescribing interventions may be around supporting somebody to reduce and detox safely, but we're also saying that for some people, prescribing may be an initial harm reduction intervention. And I know that Trina will talk more to this today. Safe as possible. Those in the consultation process and staff that we've spoken to, regular review is important. It's important to ensure that those agreed goals, those shared goals, we can check their progress, and also to review if things have not gone so well. It's normal when people are making changes to any behaviour that we'll often have a blip. So people may return to benzodiazepine use, but rather than an intervention stop automatically, instead we should seek to understand the situation within which that's happened. It's normal for us all to fall back to previous patterns of behaviour when we're under stress, for example, and we need to understand these reasons with that regular review. And again, share collaborative goals and to help the person get back on track to achieve those goals. So thank you for listening to this short introduction, and I will speak to you at the end of the webinar.
Thank you, Claire, so much for that. A very powerful call to action. Our next speaker is Isabel Trainer, consultant clinical psychologist and head of NHS 5 Addiction Psychological Therapies Services. Isabel, over to you. Thanks.
Thanks, Dave. Hi, so yep, I am going to talk about the psychosocial and psychological aspect of the interim guidance. And before I kick off, I think it's important to highlight that what we are suggesting and recommending in the guidance isn't unique to benzodiazepines, but what would be considered best practice for all substances according to the OPAS report that was published in 2018. So what we're advocating for is the availability of a matched care model, but with a particular focus on delivery of Tier 1 and Tier 2 interventions, which is all about reducing harm and achieving safety and stabilisation. So we are saying that all tiers need to be available, but that the focus is largely on Tier 1 and 2. So Tier 1 is all about the provision of psychologically and trauma-informed care, and we would expect that this is woven into all aspects of all addiction services. And Tier 2 is low-intensity psychological interventions for both benzo and co-occurring mental health or psychological problems. And these would be structured, evidence-based interventions that would require training and ongoing support and supervision. And the higher tiers tend to be offered by and provided by qualified counselling and clinical psychologists. So some examples of what Tier 1 skills or interventions would look like include, as Claire has touched on, the establishment and ongoing development of a therapeutic relationship, and also being able to provide education about the impact and effect of benzodiazepines, having awareness of some of the difficulties that are related to this in terms of cognitive impairment, and also being able to skillfully set goals and carry out comprehensive assessments, including risk assessments. And as Claire mentioned, that includes risk of prescribing and not prescribing. In terms of Tier 2 interventions, we're thinking more along the lines of motivational interviewing and interventions that help people to develop emotion regulation and compassionate resilience, and also being able to provide trauma-informed psychoeducation around developing safety and stabilisation. So these lists are not exhaustive and they're not prescriptive. One size certainly doesn't fit all. But what is going to let you know what intervention to do is the psychological assessment and formulation, which I'm going to come on and talk about in a wee bit more detail. But I have put those up to give you a flavour and an idea of what we're talking about when we're thinking of Tier 1 and 2 interventions. So those are the interventions and the tiers that we are recommending. So how do we know what intervention? Well, whatever intervention is identified, whether it's psychological, whether it is medical or social, it all needs to happen as part of a recovery care plan. And the interventions identified as being appropriate and suitable will very much be based on the comprehensive holistic assessment and formulation. And I'm going to spend quite a bit of time talking about formulation in the next few slides. But part of this assessment and identification of interventions is also about identifying whether a prescription is indeed necessary or required. So as Claire just previously touched on, we have focused on empathic listening in the guide, and as the feedback from the focus groups demonstrated, one of the things that is really important to people is the therapeutic relationship. And we cannot underestimate the importance and power of this. It really is the vehicle that can drive change forward. And without a trusting, strong therapeutic relationship, no intervention can really take place. And we also can't underestimate how difficult it is for many of our service users to develop a therapeutic relationship or any form of relationship if they have experienced significant childhood adversities, multiple traumas, and their experience of care is abusive and disempowering. You can fully understand and appreciate why it is difficult for people to access and seek help and support. If people then feel that they have not been listened to, or they're being judged in some way for their benzo use, and they can't have these open conversations, that is going to act as another barrier and another risk factor to the ongoing harm caused by benzo use. So we need to see people regularly. You know, if we want to build up that relationship, we also need to have a consistent approach where ideally it will be the same worker seeing the person on a regular basis. And we really need to respond to people that develops a form of acceptance, trust and collaboration. This is critical. Without this, we cannot go on to do any meaningful work. So what we're trying to do when we are empathically listening and building up the therapeutic relationship is we're trying to really get to know what is the function of the person's benzo use. Is it to cope with trauma? Is it to cope with the way they feel about themselves? What exactly is going on and what keeps them in active addiction? What are the factors that are making it like, why do they want to change? Why have they had a 15-year relationship with benzos, but now they want to change? What has brought them into services? Or what is what are the factors that are keeping people stuck and not being able to move on and make changes? What is the person's substance use goals? It doesn't matter what your substance use goals are. It's about putting the person at the front and centre of your assessment and trying to identify what is right for them. And at the same time, you're trying to understand how motivated or not someone is. And if you identify that someone isn't motivated, that would perhaps indicate that a period of motivational enhancement is necessary. It's also really important through this process of assessment and engagement to really get a grip of what has worked well in the past, if they have had any successful attempts of getting off benzos, what was it that helped, and equally what was it that didn't help, what didn't work so well, because we don't want to repeat that same pattern. But most importantly, we really need to be willing to have an open and non-judgmental discussion about benzo use. In terms of the needs-based assessment, what we're trying to do is really get alongside someone, collaborate with them and understand their whole life story in terms of factors that have made it more likely that someone will develop difficulties with benzo use, factors that are keeping them in their current situation, and things that are making things that might act as protective factors. And this is a psychological formulation. And I appreciate that for some of the audience today, this term might be something that you've never heard. So I'm going to spend the next few slides talking in a wee bit more detail about what that means. But in a nutshell, it's the bridge between the assessment and the intervention. So it's the bit in the middle. It's about making sense of the information that you gather during the holistic assessment, and that it will give you a good pointer in terms of what the right intervention will be and in what order that might also be most helpful to deliver. So what is a formulation? So you get all the information during the assessment, and you can be getting information about the person's current situation. You might be getting information about a current crisis that they're facing, about their housing issues, their health issues, their benzo use, any other substance use. You might be getting information about their past. And then family members might come in and give you other information. Different services might also have some things that they want to tell you about, and you might look at the records. And so you've got all of this information, and that can, what do you do with all this information? Well, a formulation gives you a framework to understand and make sense of all of that information. It offers a working hypothesis or educated guess about what is going on, about what has caused the person's problems and what is keeping them going. In practice, a formulation is used to give you a bit of a roadmap of how to improve things. So when you identify the things that are keeping the problems going, that can give you a roadmap of the changes that someone can make. So a psychological formulation is something that we do alongside our clients. It's not something that we do to them. So it really is a collaborative approach. It's about trying to identify what interventions are likely to be most appropriate and what does the person actually want. What are the factors that have contributed to or caused and also maintain the presenting problems that are sitting in front of you. Now, we can begin to formulate as soon as we see someone, as soon as we begin to build up that therapeutic relationship, as soon as we begin to empathically listen and have these open conversations about benzo use, we can start to make links and make sense of why someone is presenting with the difficulties that they have. And then we can start to set goals that are realistic and achievable and that are in line with what the service user is seeking to change. As I've already mentioned, a good way of thinking about the formulation is the bridge between the assessment and treatment. Often in services, in busy services, we see the problem and we go right in with the solution. And sometimes that might work, but a lot of times that doesn't fit the bill, because we're not getting the function of the use right, or the function of the coping mechanisms right. The formulation gives us more information about all of that, and means that we are going to tailor what interventions are appropriate and necessary to the person's needs. So it provides a clear and conceptual rationale and justification for the treatment plan. It will be very clear and obvious about why you're offering whatever intervention is deemed appropriate. So the aim is to improve understanding of what the person needs and how we can best help. A formulation can also help us as service providers or clinicians to adapt the way that we try to engage with people. Given the difficulties inherent in relationships for people who have experienced complex trauma, then we can start to understand why they might be engaging with ourselves the way that they are, in terms of they're being avoidant or over-relying or not giving much information away. If it is identified via the formulation that developing a trusting relationships is very difficult, then we can perhaps have more patience and tolerance and think about different ways that we might work with people. So another helpful way of thinking about a formulation is it like being as two people doing a jigsaw. And the pieces of the jigsaw are like pieces of information. So for instance, when did the problem start? How much benzos is the person using? What are the key experiences that this person has went through? What pain and suffering have they endured? And what coping mechanisms have they developed as a result of their experiences? Now, some of the pieces of the puzzle, it will be quite obvious how they fit together, but for others, we might mismatch it, and that's okay, because formulation isn't set in stone. It's something that we can revisit and build upon. It's an evolving process, but it is important to think about the fact that you can start to formulate and set goals right from the outset, and therefore reduce harm. And that's from the minute that we begin to assess someone. But how long a full formulation takes really does depend on how complex that jigsaw is. So formulations are a way to fully understand the problem, to know how best to intervene and support someone in their current situation. It is really that holistic, person-centred approach to understanding why this person is presenting with these problems, what is keeping them going, and how we can best help. Formulation should be jointly agreed. As I mentioned, it's not something that we are doing to people. It's something that we're doing jointly with people, alongside people. It's a collaboration. And they should be easy to understand. The whole point of a formulation is to empower people to have a better sense of how their problems have developed, to understand that what they have went through isn't their fault, and that actually their current problems are understandable given their life histories and experiences. And there will be no two formulations that will be the same. They're unique, and that is why they are very good at identifying the appropriate interventions, because it's specific to that person, and therefore it has better interventions that have used a formulation have got better outcomes than interventions that have no formulation. And formulation should also be regularly reviewed to check the information is still correct. So it's as I said, it's an evolving process, and it's something that as we gather more information, as the therapeutic relationship builds up and trust builds up, and the more stable people become and the more clearer their heads become and they give you more information, you can always add to the formulation and therefore, again, identify further interventions that might be helpful. There are many models of formulation, but in the guidance we have focused on the 5 Ps model of case formulation. And some of the benefits of using this model include the fact that it identifies factors that have contributed to benzo and mental health or psychological difficulties. It can also help to identify the nature of the dependency, including the severity and duration. And it can also help to identify factors that keep the person in active addiction, and therefore factors that we might want to intervene with. And most importantly, it helps to identify strengths and personal resources and supports that act as protective factors or buffers against some of the ongoing difficulties. So using this model, the factors that we'll identify that will help to inform the care and treatment plan include the presenting issues. So what are the immediate concerns? So for instance, is the person's current benzo use placing them at risk or harm? The predisposing factors include early life experiences, but these are factors that have made it more likely that someone has developed their current presenting problems. So you want to know what has happened to this person that has made them more vulnerable to their current difficulties. And precipitating factors, so this is triggers, why now? What are the triggers for use, for benzo use and other things? And what are the things that are maintaining or perpetuating the current pattern that the patient is presenting with? So how are the presenting problems being maintained? And lastly, protective factors, again, as I've just mentioned, what strengths, skills and resources does the person have? What existing supports are in place that we can build and draw upon when we are thinking about intervening? So this is a visual diagram of what it might look like if you draw out a formulation in collaboration with your service user. And this has the 5 Ps. And the point of putting this up here is to show that all of this information is connected and linked together. And this can help people to see where they might want to break the cycle. A more simpler way of looking at it is in this maintenance cycle, where you might want to identify what the triggers for use are, the corresponding thoughts, feelings and behaviours that are maintaining the person's benzo use or psychological difficulties, and where the person can reasonably start to make steps in terms of change, reducing harm, and trying to work towards safety and stabilisation. So to conclude the information about formulation, formulations provide an opportunity for a shared understanding of a person's difficulties, and they can offer a way of answering the classic questions of why this person, why this problem, and why now. And most importantly, it can also help to provide a rationale and shared agenda for what to target and what order, and this includes medical interventions. So some take-home messages from me would be that formulating benzo or any substance use problems and psychological difficulties is the way forward. Formulating can provide an increased sense of hope and understanding, so it's empowering to not just the service user but also to service providers, because it can help make sense of really risky behaviours and revolving door scenarios, and just give that sense of optimism. It can help to move people on, and it can help to boost staff morale. And in order to be able to do this, what is needed is a strong therapeutic relationship. And to achieve that, we need to be listening empathically to our service users, what they need and what is going on for them, and be willing to have open conversations. So in summary, what we're seeing in the guidance in terms of psychosocial and psychological interventions is that a matched care model needs to be available, that we need to do things differently. We can't just prescribe in isolation. We need to do joined up working. We really do need to be working in partnership, health, social care, statutory and non-statutory services. We need to listen to our service users and help them make sense of their benzo use in the context of their unique life story. And key to this is we need to see people regularly and take a consistent approach to their care and treatment. It's a closing question. I think Claire is going to have some questions at the end, but while I was preparing my slide, the question that I was wondering about, or what was on my mind, was, well, that's very well and good, but what would a service look like, or what resources would be required to be in place in order to fully meet the psychosocial and physical needs of people with benzodiazepine problems. Thank you for listening.
Thanks, Isabel. That's a really helpful presentation. We're now going to move on to our final speaker and then have some final comments from Claire Campbell. Our next speaker is Trina Ritchie, clinical lead and senior medical officer with Glasgow Alcohol and Drug Recovery Services. Trina, thanks.
Thanks, Dave. Thanks for the slides, Emily. I'm Trina Ritchie. I'm working as a lead clinician in Glasgow Alcohol and Drug Recovery Services. Trained as a GP, and I've worked in alcohol and drug services for over 15 years. Might be slightly exaggerating if I said I've hardly slept all week thinking about this talk and how I'm going to fit talking about prescribing benzodiazepines into a short presentation today. Then I was looking at papers and guidance and seeing that every single one of them mentioned controversy, and wondering how I was going to fit in talking about that over the years and how I think it's affected prescribing practice. And then I really realised that the anxiety about benzodiazepine prescribing is old news in Scotland. We're past that because of the extent of harm that is our current situation. Claire's already introduced our benzos guidance. I really just wanted to touch on one point in particular that's been made already this afternoon, and really thinking as a prescriber, because I found it quite striking from the consultation feedback, and that's our responsibility to start a conversation, not to wait for somebody to be asking about benzodiazepine prescribing. Claire spoke about it a bit, but I do think it's something that we need to be very mindful of, and I really wanted to emphasize. For me, the zone of tolerance in our guidance is the crux of changing practice. So we're aware of the direct and indirect harms from street benzodiazepines. How good are we at actually taking the time to detail them and to record them? You know, from overdoses, A&E attendances, to people becoming victims or perpetrators of crimes due to experiencing loss of appropriate decision making. Bloodborne virus risks, you know, we know that there's many. Risks of prescribing. All medications have risks of prescribing. Most medications have big long lists, you know, paracetamol, simvastatin, and the risks of benzodiazepines are very well, the prescribing risks, you know, we call them side effects or adverse effects, they're very well documented, but documented as a comparison with not taking them. And I also think we need to be mindful of that. You know, and the risks are, as we know, drowsiness, falls, respiratory depression, probably the ones that are of most importance, along with possibly cognitive impairment. We can't pretend that they don't exist, but we need to think of them against the risks of not prescribing. If we don't prescribe and somebody is already being advised on other harm reduction steps, if we don't act, then the risk won't reduce. I didn't want to move on to talk about prescribing without mentioning harm reduction intervention. This is a CREW resource that's really very good, that's linked to on the Drug Death Taskforce website, and in particular the importance of that harm reduction intervention of reducing from taking mega doses. So in the guidance, it talks a bit about things to think about before prescribing. So at this point, we've moved on from our formulation, and we've decided that prescribing for this person, made the joint decision that it's the most appropriate step. We need to obviously have informed consent. That's really just documenting and formalising the zone of tolerance discussions that have been going on and the shared agreement about risk. Realistic harm reduction goals. I think this is the most straightforward bit. If you spend all of that energy describing the harms that someone is experiencing, then your goals are to jointly come to a shared agreement of which ones are priorities for both parties and say that those are the ones that we want to see reduce with benzodiazepine prescribing. I think it's probably important, it's implicit, but it's important to be explicit to say that for many people in this situation, the goal will not be total abstinence from street benzodiazepine use. We are discussing here reducing the observed harms. And that point that I'm making in particular reference to further on in the guidance when we talk about monitoring and reviewing progress, that we should be mindful of that if, for example, in a drug screen, if there are street benzodiazepines in a drug screen, not to lose sight that our harm reduction goals may not be abstinence at that time. And really importantly, a shared understanding of what the agreed plan is if harms don't reduce. If a benzodiazepine prescription is agreed and started, what if overdose and A&E attendance markedly increases after that? So there needs to be a joint understanding and plan around that. Section 410 of the National Drug Treatment Guidance, I think, is often cited as overly cautious around benzodiazepine prescribing, and I think it's also used to support decisions not to prescribe. But I don't agree with either of those things, actually. If you read the detail, it actually supports consistency of practice, good assessment, a period of stabilisation, talks about exceptional circumstances, which I would equate with this extreme level of harm. And in those circumstances, it talks about a need for longer term prescribing, setting goals, milestones and reviews. It also talks about potential need for slightly higher dose prescribing, 40 or 50 milligrams a day. I'll talk about dose in the next slide. And it talks about an individual-led detox taper. So within the guidance produced by the working group, we have outlined what we believe to be established good practice prescribing principles. And they're very much in line, as I've said, with already peer-reviewed and published guidance. So prescribing a single benzodiazepine, Diazepam is the usual choice because of its long half-life and the range of strengths of tablets that it comes in. It is usual in most circumstances to try to keep the maximum dose to 30 milligrams because it's thought that you're less likely to have adverse effects at that dose. But as I've said, there is some guidance there to suggest that in some cases you may need slightly more than 30 milligrams. Then we've said when risks are particularly high, you may want to start at a lower dose and move upwards. And this really has been feedback from colleagues in the city centre in Edinburgh and Glasgow, working with particularly high risk populations, who found that starting at 10 or 20 milligrams to look at the impact of prescribing and monitor the risk has been a helpful step. So we talk about making use of daily or frequent instalment dispensing at the community pharmacy. Short-term goal of stabilisation of street benzodiazepine use. And I guess I'd go a step further and say, why rush? And I'll illustrate that with something that happened at the start of the pandemic in one of the sectors in Glasgow, where it just happened that a number of people were being started on what was intended to be a benzodiazepine prescribing intervention of a detox intervention. The pandemic started, and the decision was made jointly that actually it would probably be best for a period of time to just stay at a steady dose because of the reduced amount of support that was available, except for virtual meetings and things which people were having some issue having the appropriate resources to link into. So now that people are looking to begin those detoxes, The people who've been kept maintained for a year, although it happened in an unplanned way, have described it as life-changing and have recognised that they were, although requesting a detox, were able to address lots of other factors that were going on for them and now felt really well prepared to start their reductions. And I guess linked to that is our thought that if harm is reducing with a prescription, it might be safest to continue that prescription. And also that a detox should be led by the individual. Again, in preparing for today, I found what I thought was a really good description of individual-led detox, which says, set a goal of gradually working to find the lowest effective dose, which over time might become less or none. I just thought it quite appealed to me. Importantly, what we've said is that this is not just a prescription, and I think that that's been really extensively outlined already by Claire and Isabel with her psychosocial and psychological interventions. And there should be regular monitoring and goal setting and review of goals. So just returning to zone of tolerance briefly, I think implicit here is the risk of judging people as deserving or undeserving. And I think that's why one of the reasons why we keep emphasising that assessment and decisions around benzodiazepine harm reduction must be patient-centred, and they must achieve a shared understanding of, or an explicit understanding of shared risk. In terms of saying earlier that I'd hardly slept and how would I fit this into the time, well, as you'll see, my presentation's actually been quite short, and in reflecting on that, I realised that there's very little new about benzodiazepine prescribing. It exists, and how to prescribe safely exists in current literature. And what we are saying is different is the need to act and the need to reframe the risk balance and the acceptance of risk and tolerance of risk. Claire's going to come on and talk about next steps in the consultation, but I guess what I would like to say to prescribers who are listening today is that this is not a consultation in terms of sharing this guidance and then expecting further versions, which we do, we do expect to have a consultation period. But this guidance really is, as we say, a call to action, and as it doesn't contain anything particularly new around benzodiazepine prescribing, we would ask that people re-examine their tolerance of risk and their benzodiazepine prescribing actions. Thank you.
Thank you so much, Trina, for that, and another very powerful presentation. Can I ask now Claire to come back in to summarise the next steps from the working group? Claire, thanks.
Thanks, Dave. I'm conscious of time, so on the slide you will see the next steps that we have within the benzodiazepine working group. We are going to open from today a 4-week period for feedback on the guidance that we've presented, and I'll talk more to that in my next slide, and an ongoing programme of consultation. We will continue to scope out the recommendation that we have made to the Drug Death Taskforce around residential beds for those to provide a sense of immediate physical safety and to support stabilisation, and a wider programme of engagement, with a conference planned at the end of the year to confirm the consensus. Hopefully today's webinar has illustrated that right now it's within your gift to do something different, to provide a compassionate response and to give people a different experience. We are seeking your views and opinions on the interim guidance. This matters, and I guess we're practicing what we preach by looking at the B in the benzos, having that conversation and opening up a dialogue about benzodiazepine-related harm and what we can do to make that difference in people's lives. So you should have received a link to the invite to the webinar today to a SurveyMonkey questionnaire that is going to ask the following questions. Do you agree with the overarching principles of benzos? And if you don't, What would be your suggested alternative? What support and/or resources might you need to implement this guidance? And would you see any challenges to implementation? A question and answer session at the end of a webinar would not have given justice to all of the diverse views of those attending today and of those who may be watching this recorded. We meaningfully want to engage, we meaningfully want to have that dialogue where we empathically listen to your views in order that we can make a difference. Thank you.
Thank you, Claire, and thanks to everyone who's contributed today. We've come to the end of the webinar. So finally, I would like to thank all of you for attending, and a special thanks to today's speakers for what has been a very interesting and informative webinar and an absolutely important call for action for all of us. Thanks again, and goodbye for now. Thank you.